On March 20th, 2020, Dr. Jurgen Unutzer was scheduled to speak at Horizon House on the topic Improving Mental Health Care in Our Region. But that talk, as you are well aware, like so many other talks, was canceled because of the onset of the COVID pandemic. So 3 years and almost to the date later, Dr. Unutzer is finally with us, and with an intervening COVID pandemic and associated mental health crisis, I'm sure what he's going to talk about has relevance to this particular audience. Dr. Unutzer is professor and chair of the Department of Psychiatry at the University of Washington School of Medicine, and as such, he has developed the largest psychiatry residency program in the United States, one that promotes the integration of evidence-based mental health treatments with general medical practice. He's acquired state funding for a new state-of-the-art behavioral health teaching hospital located on the UW Northgate campus now. I think it's about to open, right? And he's acquired state funding for statewide psychiatric consultation programs for clinicians in every county in Washington State. He's received a $50 million gift to establish an Institute for Brain Health Solutions at UW Medical Center, which joins with the Behavioral Health Institute at Harborview to bring together multidisciplinary groups of scholars, researchers, and clinicians to study the full range of disorders and conditions related to brain health, and he'll tell you more about that later in his talk. All of these accomplishments are significant research and training programs, and they're consistent with the mandate of a major research institution like the University of Washington. And what Dr. Unutzer will discuss today are the implications of these and other developments for meeting the complex mental health needs for our region. Please join me, finally, in welcoming Dr. Jurgen Unutzer.
Well, thank you for this nice introduction, Jack. I'm not sure I can live up to all those nice things that you just said, but I'm going to do my best. Hi everybody. My name is Jurgen. As Jack said, my day job is I chair the Department of Psychiatry at UW. And I'm going to say a few things about, this is on wheels, okay, I'll be careful. I'll say a few things about brain and brain health, a little bit about mental health, and then a lot about different ways we're trying to help people who are struggling with mental health and addiction problems. And I'm not going to be able to answer all of the things that are in your minds and all the questions you have, so I'll try to stop about 45 minutes in, and then we'll have time for some questions, and if we can't figure out all the questions, then I'm happy to follow up with people afterwards as well. Does that sound okay? Okay, great. Okay, so, I'm going to start with something very, very simple. This is what I call Brain 101. Just because everybody here has a different understanding of what is that thing in your skull. So I'm going to tell you a little bit about that thing in your skull. So I'm a psychiatrist, think about the brain, other doctors think about other organs, the heart, the lungs, the kidneys. They're all important. Of course, I'm a little bit biased, so I think the brain is the most important. And here's why. So your brain it weighs about 3 pounds. It makes up about 2% of our body weight. And what is it made out of? 75% of it is just water. And that thing, that 3-pound thing in your skull uses up 20% of your body's energy. So what's inside that 3-pound squishy organ? There's 100 billion little nerve cells called neurons. There's also 100 billion little support cells that we call glia. And those cells, those little nerve cells, they're connected with each other in 100 trillion connections. So nobody can imagine what 100 trillion is, right? I can't, but just think about that. So nobody's ever built a computer that's got 100 trillion connections, but every one of you has one of those in their head, right? That's pretty cool if you think about it. So if you think about that, that makes up a very complex kind of circuitry. We could call that sometimes the connectome, so the way in which all of these things are connected to each other. And it's by far the most complex organ we have. So that's why I like it, and I think why it's maybe the most important thing that's we have in our bodies. What do you do with a healthy brain? Well, your brain does a lot of things. It helps you process information. It helps you process what I'm doing here right now. It helps you create consciousness and experiences. It makes you able to reflect on the fact that you are here and that there are other people around you. It helps us create memories. It helps us solve problems. It controls the way you think, the way you feel, the way you behave. It controls your actions, your speech, and it kind of makes who you are. So we all have different personalities, and you know, the way I think about that is we're all not wired the same, because we have these 100 billion nerve cells and 100 trillion connections, and if you look at that, none of us are the same, and it kind of shapes who we are and how we act and how we feel, and that's, I think, really interesting. So that's Brain 101. So I'm sure there are people who know a lot more about the brain here, and I'm sorry if I offended anybody, but that's just so we have something to work from here. Okay, now I'm going to do another 101. So I'm going to do mental health 101. So there's people like Jack and Sam and I and others who think about mental health a lot, and we could do a lot of more than that, but I'm going to try to do some very basic stuff. So if you think about what drives your mental health, your mental well-being, well, I think about three things. So there is the brain. So to think about the brain as your computer, that's your hardware, that's your biology. And then there is the environment that we're all put in. There's stuff that happens to us and with us in our environment, and that biology, that computer interacts with what's going on in your environment, and then you have different life experiences. We all have different life experiences, and I think that shapes you know, what our psychology is. That shapes how we cope with different things, how we perceive things, what we think about, what we feel when things happen. And it's all different because we've had different brains with different environments. They create different life experiences, and it makes us different. And then in terms of mental health, I think that you know, mental health isn't a thing you either have or you don't have. It's on a spectrum, right? And the spectrum goes from perfect happiness, well-being, to, you know, not so good today, I'm in a crisis, I have a lot of distress, to I'm constantly in a crisis and I'm constantly distressed and in a lot of, you know, emotional pain. And that would be the spectrum from complete well-being to mental illness. And most of us on any given day are somewhere on that spectrum. We're not either all well or all bad, you know, and that's another interesting thing. So you can think of yourself of where am I on that spectrum? Where are my kids on that spectrum? Where are my grandkids on that spectrum, right? And it changes. So I'm going to just, to make this a little more concrete, let's think about the COVID-19 pandemic. So when that thing first came at us, well, most of us got anxious. And so most of us hadn't even seen or met anybody with COVID yet, but we had a lot of what I call anticipatory anxiety. We worried about stuff that might come at us, but it's not come at us yet, but we worried a ton. Some of us worried more about it before you know, it really came at us than when it actually did come at us, because when it came at us, you just found your way through it. You know, so you have anticipatory anxiety, you have a lot of acute stress. Some of us went through horrible experiences with it. We got sick ourselves, our loved ones got sick, and we had tremendous trauma from that. And then after you lose somebody, you have grief, you have loss. And those are not mental illnesses. Those are all normal things. Those are things that happen to us. So I just want to make sure that we can differentiate what I think are normal things that go on in our emotions and our life experiences from things maybe that are more than that. So that's different from what we call in the business things like clinical depression or things like post-traumatic stress disorder. Those things they may start with a normal reaction to a stressor, but what happens is they become very persistent and you can't shake them and they don't leave you and they really become disabling. And then we think about the fact that you might be struggling with a mental health problem. And so there are different kinds of ways that you could go with that. So some of us get a tremendous amount of anxiety, so we're worried all the time. We can't stop worrying. What's the next thing that's going to come at us? And it just consumes you and you can't find your way out and that's all you're thinking about. Some of us, if you're anxious long enough, it's really exhausting to be anxious all the time. Then you get depressed. You're like, this is hopeless. I'm always going to be this way. I'm always going to be anxious. I can't find my way out, and you kind of get depressed. It's almost like you're hopeless. You're giving up. And then some of us are, start doing behaviors that are not good for us. So you might say, this is so stressful, I need to have a drink. Maybe I need to have a couple drinks. Maybe I need to be drinking all the time. That's a good way to cope maybe in the short run, but it could catch up with you. So there's lots of maladaptive coping that can happen in a stressful situation like this. So speaking of coping, how do we cope with stressors? I go back to the thing at the very top of this slide. Some of us have computers, hardware, brains that cope better than others. Some of us have had life experiences that have taught us how to cope with things. Because we've been through something stressful, we figured out how to master it, and so we're ready for something else. Some of us haven't had those kinds of experiences, so when a big stressor comes at us, we get totally overwhelmed. All of these things are shaped by those three things. What is your brain like on any given day? What life experiences have you had? What kind of coping strategies have you had? And that's, I think, what makes up a lot of what we do in our business. Helping people sort that out and saying, where are you at right now? What's been your experience so far? What can we do to help? So again, that's very short, and there's a lot more to it, but that's sort of just a set of bases here. So what happens when things go wrong with your brain, with your mental health? So when things go wrong, and they will often go wrong, you develop either some very severe forms of mental illness. We all know somebody who struggles with things like autism or schizophrenia or bipolar disorder. The way I think about those kinds of illnesses, it really is often somebody where the brain literally breaks. Something goes wrong, and it breaks in a bad way. Some of us have more common mental health problems. Many of us have struggled with depression, with anxiety, with addiction problems. As our brains get older, they can break down. Some of us struggle with things like cognitive impairment, dementia. That could be from a stroke, it could be from Alzheimer's disease, and some of us struggle with what I call sort of risky health behaviors. And this isn't something that happens rarely. This is something that happens, I don't know a family, and this is maybe because of what I do, but I frankly have never met a family that hasn't had somebody in their life who at some point has struggled with one of these problems. So it's very common, and I put some pictures of some very famous people that many of you will recognize who were quite public about the fact that they struggled with these illnesses. And the reason I put those pictures is because I think we all need to become comfortable saying, this isn't some weird thing that happens to strange people somewhere else. This is something that could happen to me, that could happen to my kids, that could happen to my grandkids. And if we can say that, then we can be in a better position to try to really do something about it. Okay. What about the cost of all of this? And I'm not going to go through all of the things that are on this slide. I'm happy to share these slides with you when we get done. But the bottom line is, there is good research now that says that mental health and addiction problems affect nearly half of the world's population at some point in their lives. And the cost is enormous. And what we have learned is that mental health and addiction problem cause about 30% of all disability that's related to anything related to health. So you might say, and in fact it's 5 times more disability than diabetes or heart disease. It's 15 times more disability caused by mental health problems than cancer. Now you would say, wait a minute. Cancer is a terrible thing, and I know people who've died from cancer, and if I got cancer, it would be a horrible thing. That is true. The big difference is when it comes at you. So if you think about that, most of us, if we're going to have cancer, it comes at us in our 60s, in our 70s, maybe in our 80s, and then it can be very bad. But maybe we have treatment, and we can have a reasonable life with it, or maybe we can't fix it, but we end up losing a few years at the end of our lives related to cancer. For most people who have mental health or addiction problems, it comes at us very early in life. So 50% of the people who will have one of those major mental health problems that I just listed earlier are going to present with that by the time they're 14 years old. And then 75% of the people who will have one of these problems will present with it by the time they're 24 years old. So what does that mean? That means then you have something that's a huge impact on your life, and you've got to spend the rest of your life with it. And that's why the cumulative burden of these problems is so much greater than something that we all worry about, things like cancer. So I think that's an important thing to kind of understand. It has a huge impact on us. You know, you can look at it, for people who live with it, it makes it hard for them to do the things that we all like to do, to love people, to work, to do very important things. You know, we don't have to go very far. If you go a couple blocks from here, you will see people on the street who are struggling with mental health and addiction problems. You know, we have in this country now a suicide every 13 minutes, and somebody dying from a drug overdose every 8 minutes. You know, it's an enormous, and that's gone up in the last couple of years, especially the drug overdose part. It's a very expensive, very, very disabling problem. So I could say a lot about that, but I don't want to get you too depressed. I want to see if we can go on to some solutions here. Just a couple more slides to give you a sense of the magnitude of this problem. So if you think about all these little people here, if these are all the people in Seattle who are living right now with a diagnosable mental health or addiction problem, how many of them will see a psychiatrist sometime in the next 12 months? Anybody want to make a guess? One. Okay, it's better than that. 10%, 12%. And I say this because I say this to my colleagues. We have a big department of psychiatry. There's 300 of us, and I say, this is all you guys can do. You're helping 10% of the population who is struggling with this, just to kind of make their day. No, I'm just kidding. But they'll say, okay, well, there's not just psychiatrists. There's psychologists, there's social workers, there's marriage and family therapists. There are lots of people who have training to help somebody struggling with a mental health and addiction problem. And if you take all those people and you include pastoral counseling, anybody who we think has some training to help a person struggling with a mental health or addiction problem, if you go back to all of those people who right now have a diagnosable mental health or addiction problem in Seattle, and over the next 12 months, how many of them will have at least one meeting with somebody who has any kind of training in this? 20%. 1 out of 5. Okay. The good news is about 40% of people will say, sometime in the last year, I saw my primary care doctor and they did something to help me with depression, with anxiety, with an addiction problem. So this is, in my mind, this is the opportunity. This is the glass is half full. Now these are not people who are trained to help you with a mental health problem, but they have a chance to meet you, to engage with you. And this is something I'll get back to a little bit later. But the bad news is 60% of people who are struggling with these things will get nothing whatsoever, not a single encounter with anybody. Now think about back to, what if this was cancer? What if we had to say, only 10%, 12% of the people who have cancer in Seattle today will get to see a cancer doctor sometime in the next 12 months. 20% will get to see anybody. 40% will get to see a primary care doctor for their cancer. 60% will get nothing at all. We would find that totally unacceptable, right? But I just told you earlier that this causes more damage than 15 times more disability than cancer will cause. This is where we're at. We have a huge gap in the ability to meet the needs of people who struggle with these disorders. And there are a lot of reasons for it. Some of it is us. We're not so comfortable talking about mental health and addiction problems. People have gotten more comfortable. When I was in training in medical school, people didn't want to talk about cancer either. They were really afraid of it. I trained in the South. I was at Vanderbilt. We had a lot of people who said, it's the C word, I don't want to talk about it, I don't want my neighbors to know that I have it. That has changed because now we're saying, hey, this is a problem, this is a health problem, it can be fixed, let's talk about it. I think we're not quite there yet with mental health, but we're getting there. We're closer to that than we were when I got started in this business. So a little bit about what are we doing here in Washington State. So about 1 out of 5 people who live in Washington today, I would say, are struggling with a diagnosable mental health or addiction problem. That's about 1 million Washingtonians. And this has not gotten better, during the last 3 years of the pandemic. It has not been good for most of our mental health. So we have a big challenge. And what do we do in terms of helping people like this? So we are, as a state, rated very highly on almost any health indicator that anybody's ever measured. If you look at things like, childhood mortality, if you look at overall life expectancy, Washington is a very healthy state. Some of you are here because of that. It's a good place to be. When it comes to access to mental health care, we're not rated very highly. We were rated most recently in 2020, 46 out of 51 in terms of US state, in terms of access to mental health care. We have very long waits for people who need care. We have huge shortages in our workforce. And those are some of the problems that we are trying to address now. We have a state hospital that is the single largest facility caring for people who have really severe mental illness. It's a facility that was built in the year 1871. This is what it looked like back then, and it still looks like that way today. It's a pretty scary looking place. And this is or the people who live in our state who have the most serious mental illness spend a huge amount of their time. And this really bothers me because, as a brain health and mental health doctor, I'm thinking to myself, if it's more important than heart disease and cancer, why do we have to take care of people in a place that was built in 1871? This was actually built as an army fort. And sometime in about 30 years after it was built, the U.S. Army said this is a facility that's no longer fit to help healthy young soldiers. So it was turned into a state mental asylum, and it's been that way ever since. If I think about that, I'm working in a big academic healthcare system. If you get cancer, you go to a beautiful facility on South Lake Union with modern architecture and modern machines and doctors who are happy to see you. And if your brain breaks and you have schizophrenia and we can't fix you with a short-term hospital stay, you might end up getting your care in this place. So that's not to say anything negative about the people who work there, because it's really important to do this work. I'm not trying to criticize them. I'm just trying to say, as a state, we've made some choices that have not really valued mental health and brain health stuff. What are we doing? A lot of people who many years ago were in getting mental health treatment in a mental health hospital somewhere, where are they now? They're in jails or in prisons. There are more people with mental health problems in the King County Jail right now, or in the LA County Jail right now, than are in any of the inpatient psychiatric facilities in our state. It's a real shame, because as this poster says, a jail is not a good place, or a prison is not a good place to help somebody who got picked up because they were doing something that's a nuisance, because their brain is broken and they're hearing voices telling them to do things. That's a terrible solution, and it's also a very expensive solution. So I've just spent almost a half hour telling you lots of bad things, lots of problems. So I'm going to try to switch gears a little bit and say, what are we doing to try to fix some of this stuff? So this is a slide that's too complicated, but I'll just point out a few things. This is an effort to sort of say, what are we doing at UW-Medicine to close some of these gaps? And there's sort of four strategies. So on the top left, if you're in a serious crisis, or somebody who you love is in a serious mental health crisis, you are sick, you're psychotic, you're hallucinating, your brain breaks, you're seriously depressed, you can go up the street to Harborview Medical Center. That's the only place in town that will have a psychiatrist to see you 24/7, 365 days a year. We're happy to see you. We're happy to see your family members, your loved ones. It's the only place in the state of Washington that has 24/7 in-person psychiatric care. A couple of years ago, the voters in King County passed a bond measure that will give us over $1 billion to try to make a huge improvement at Harborview, including a brand new Behavioral Health Institute facility that will really dial up sort of our capacity to help people with an acute crisis. So this is what happens in an acute crisis. On the top right, let's say you get past the acute crisis, but you have a very difficult case of schizophrenia, of post-traumatic stress disorder, something that really needs longer-term, good inpatient care. We don't want you to have to go here. We got, as Jack said, a couple years ago, $250 million from the state of Washington to partner with the state to build a brand new teaching facility to provide longer-term care that will go up on the Northwest Hospital campus of UW-Medicine. I'll show you some pictures about that towards the end. The bottom left, we have, I think, for the most part, some reasonably good treatments for many of the mental health and addiction problem, but we need better treatments. So we got $50 million, a wonderful gift from philanthropists Mike and Lynn Garvey, local philanthropists that are helping us do research to help find better treatments, better solutions. And I'll say a bit more about that as well. And then on the bottom right here, there's many people all over the state of Washington. Like I said, they might be seeing their primary care doctor, maybe a pediatrician, maybe a geriatrician, maybe an internist, and they're presenting with a mental health problem, and those doctors aren't trained to deal with mental health per se. So what we do now is we've set up a 24/7 consult line where any doctor anywhere in the state of Washington can call us 24/7, 365 days a year and talk to us about one of their patients. And we have a psychiatrist. We'll talk them through how to make a diagnosis, what to do, and we can even see the patient using telehealth if we feel like we need to see the patient ourselves. So there are 4 strategies that we sort of set out to try to come at some of these challenges. So I mentioned, the first one I mentioned is our behavioral health teaching facility. This is something that we did in partnership with Jay Inslee and our state government about 2 or 3 years ago. Governor Inslee put out a huge, very ambitious $675 million plan to say we need to upgrade our capacity to help people with mental health and addiction problem. And there are 3 things on that where we as a university are partnering. The first one is building this new facility. I'll say a bit more about that. The second one is this consultation service, because we felt like there's going to be parts of rural or even urban Washington where we're never ever going to have a psychiatrist or a psychologist, but people still need help. So we're going to make ourselves available to people all across the state to call us. And we set this up a couple years ago. I take calls on this. We have about 40 or 50 psychiatrists in our department who staff this consult line, and it's really good work. It's really rewarding work. We're getting calls. We've gotten calls from every single county in the state of Washington since we started this service. And the third one is we need a lot more people who are trained to work in this space. So we have grown our psychiatry residency program. As Jack said, we now have the largest training program training psychiatrists in the United States here at UW. We also train psychiatrists in Montana and in Idaho as part of our 5-state WWAMI program that we operate. We grew our child psychiatry program. We are starting fellowship programs for nurse practitioners in psychiatry and for physician assistants. And I'll say a little bit more about that in a bit as well. This is a little drawing of what our new behavioral health teaching facility looks like. It's in construction. It looks like this right now. It's up on the Northwest campus. It'll have 150 beds. And I won't go into a lot of the detail. It's easier to put up the outside of a building than the inside. So the building is up, but it'll take us another year to really equip it. And so sometime around about this time next year, we're going to be welcoming patients to this new building. It'll have in it it'll be a very beautiful space. It'll have some outdoor spaces, which is really important because people don't like to be cooped up indoors for a long time. And here in the Pacific Northwest, it's not that easy because it rains half of the year. So we thought very hard about how to create some spaces where people who have to be with us for treatment for a while can go outdoors and be safe. But we did some really creative work, I think, in this area. It will have on the bottom floor a center we'll call the Neuromodulation Center that's going to offer treatments that are different from traditional drug treatments or psychotherapy treatments. It will use treatments that directly stimulate the brain, either using a strong magnetic field or using electrical stimulation. So a little bit like the old style electroconvulsive treatment, but some more modern methods that are not quite as hard on your brain, using something called transcranial magnetic stimulation, and some other ways of treating people who have really hard to treat mental health and addiction problems. We are also going to have the capacity to try other novel treatments and novel therapeutics in this space. This is what it looks like when you're getting TMS, transcranial magnetic stimulation. It looks a little bit like going to the dentist and sitting in a dental chair, but what we do is we literally use a magnetic field, a very strong magnetic field, to try to affect that connectome, those circuitry that I talked to you about your brain. Sometimes what happens is, there are areas in your brain that are either too active or not active enough, and we can use that kind of stimulation to try to literally modulate how active different regions of your brain are, or how they are talking to each other. And so some of these treatments can be helpful for things like severe depression, for people who have catatonia, people who are psychotic and who really can't interact with the world very much. We can use some of these new treatments. The other thing that is unique about this facility is not just another hospital. It's built from day one as a teaching facility. So we want to train 300 to 500 professionals. We want to train in this hospital psychiatrists, psychologists, social workers, nurses, nurse practitioners, physical therapists, occupational therapists. And when you build something to do that much training, it looks a little different from just another hospital. We have to have the kinds of spaces where you can talk, where you can lecture, where people have simulation. We're putting in a simulation laboratory where people can try something on a computer simulator before they try it with a real person. So there's some really cool, interesting, teaching technology in this facility. I said a little bit about the workforce shortage we have. We have all over the United States, but on the right is the map of Washington. We have a tremendous shortage of mental health professionals. About half the counties in the state of Washington don't have a single psychiatrist or psychologist or social worker. So those are the people who are most commonly trained to deal with mental health or addiction problems. Half of the counties in our state, not a single one. So we have a lot of work we have in front of us to try to teach more people how to help. And so we're doing a whole bunch of stuff to do that. Like I said, we got last year $6 million to start a new program that teaches nurse practitioners about psychiatry. It's people who finish nurse practitioner training who want to learn how to practice psychiatry. We already have the largest psychiatry training program in the United States. We have a wonderful psychology internship program that Jack is very familiar with. It started 63 years ago. It's still going really strong, and we have tried to grow it over the last couple of years. The other thing that I have come to believe is that it's never going to be good enough just to have a couple of doctors, a couple of psychologists. I think the truth is we all need to be trained as behavioral health professionals to some extent. I feel like what you need to know to help somebody who's struggling with a mental health or addiction problem, the people who are living with the problem should know as much as possible about it. Their caregivers, their loved ones should know about it. Oftentimes people will drop a patient off with us, maybe in this new facility, and they'll say, go take care of this person, something went really wrong. And we'll do a really good job caring for the patient, and the family will come and visit, and then at some point the patient is well enough to go home, and we say, here's your loved one who's living with schizophrenia, but we haven't taught them anything. They don't know how to talk to that person. They don't really know how to work with that person. And so what I have come to believe is actually, while your loved one is in treatment with us, we should be putting you through a whole bunch of training about how do you work with somebody who has schizophrenia. How do you talk to them? When somebody sees things that you don't see, if somebody thinks things, believes things that you don't see, and they're very firm in those beliefs, how do you talk to somebody like that? How do you not just argue about it? How do you really, those are skills we can teach. And so with this new facility, I would like to actually raise a bunch of money to try to build a program that trains not just the patient, but that trains loved ones and caregivers. Because I think in the end of the day, that's who's going to be with you. So that's a little bit of a different way to think about workforce. So we could say we need to train, and we are training more doctors, more nurses, more social workers, but I think we also need to train everybody, to say, what would I know? What's mental health first aid look like? We've learned how to take care of somebody and give them first aid, but what does that look like for somebody who's struggling with a mental health or addiction problem? Or where do I go to get them more help if I'm out? This is again, I mentioned already, we have the new facility, we have a new nurse practitioner program. I'm going to skip a few of these slides, and then I'm going to shift gears a little bit. So the other thing I said earlier on is that most people today who are struggling with these problems are not coming to see a psychiatrist or a psychologist. Most of them are going to see their primary care doctor. They might see their internist. If they're a young woman, they might see a midwife or maybe an obstetrician gynecologist, and they might be really anxious or really depressed, or maybe they're struggling with an alcohol or a drug use problem. And that's a tremendous opportunity. Those doctors have relationships with their patients, and what I want to do is help those doctors recognize the problem and say, let me see if I can get you some help. So a couple of decades ago, one of my mentors here, a guy named Wayne Caton, and a good friend at Group Health, Mike Von Korf, Sam knows Mike very well, they came up with this neat idea about that we ended up evolving into a concept called collaborative care. Could you help treat people with mental health and addiction problems in primary care? And we have built on this, and we've built a very, very robust program that shows that if you give a primary care doctor the right tools, the right resources, they can actually be very, very effective in treating something with a mental health and addiction problem. And so we developed this program called Collaborative Care. We did a very, very large study. This is one of very many studies. This is the biggest study still yet to done to date, where we went into 8 clinics in 5 states, and we took 2,000 people who were struggling with serious depression, and half of them got randomly assigned to getting what we call usual care. So we said to their doctors, this is the person who has depression, do anything you can. You can put them on a medicine, you can refer them to a psychologist or a psychiatrist, but do something. And the other half, we basically gave them some tools. We taught somebody in their office how to do a brief evidence-based psychotherapy, a talk therapy. We put a psychiatrist in charge of reviewing all the patients who were getting treated in this primary care setting, not treating them themselves, but reviewing the care and giving advice to the primary care doctors about what to do. And a year later, we went and looked at all those patients, and we were more than doubling the likelihood that the patients who were depressed actually got well. So what we showed is we could help lots and lots of people in primary care if we did the right thing. And that's a very, very smart investment. We also were able to show that, and this is a study that, and it is not a study, the Wall Street Journal about 10 years ago wrote a really nice article saying when you do this, it actually saves the healthcare system money. Because for every dollar we spent on this treatment in primary care, we were able to show that in the next 4 years we were able to save $6.50 in terms of total healthcare costs. Because people who are depressed and anxious, they're not well, they're going to the doctor a lot. And sometimes what they're getting isn't exactly helping their depression or anxiety. And when we treated their depression and anxiety in primary care, it actually reduced their healthcare spending by quite a bit. And so the Wall Street Journal thought that was interesting. They wrote about that. That thing got me more attention than papers we've published in JAMA, in the New England Journal, and lots of other fancy medical journals. So I would say if you want to get attention, try to get it in the Wall Street Journal. So we've done a lot of research on this concept. It works really well, but we've also implemented it. So we now have at every one of our primary care clinics that we operate as part of UW Medicine Primary Care Network, we now have a mental health collaborative care team in place in these clinics. And that's usually a social worker working alongside a primary care doctor and a psychiatrist who backs up this team. And we've been doing that, started in 2008. We now have it operating in about 20 clinics, and it's been super, super successful. Finally, I mentioned that we set up this consultation line. So if you have a doctor anywhere in the state of Washington who has a question about what to do with a person who's a mental health problem. This is the number. You can call that number. One of us will answer that number 24/7, even in the middle of the night, even in the middle of the night on a weekend. And we'll talk them through what to do. And it's been super, super successful. The final couple comments, I'll say a little bit about philanthropy. So one of the things that struck me a couple years ago is we need a lot more investment to try to understand this complex organ, the brain, and to try to build treatments that are more effective than what we have today. And I started to say, who is funding work in this area? And I ran across a couple of studies. The first one is a study from England. And what they looked at is they said, when you look at how people use charity, how they use philanthropy, philanthropist spending on cancer treatments, on heart disease treatment and on mental health treatments, you can see these bar graphs. Almost nothing in mental health. Cancer, huge amounts of money going into cancer research, a lot of money going into heart disease research. But again, people don't really want to talk about mental health, and there's almost no money going into that. So I was very fortunate a couple years ago to develop a wonderful partnership with a couple, a local couple who are wonderful philanthropists, Mike and Lynn Garvey, and they gave us $50 million, as Jack said, to put together this thing called the Garvey Institute for Brain Health Solutions. And I'll just say a couple more things about what we're doing with this wonderful gift. So the first thing we did is we set out to do a really good mission statement, and the mission statement is pretty straightforward. It's basically we need better tools to help people with these problems. What have we done so far? We've established a really, really wonderful group of researchers at all three of the UW campuses. So UW main campus, the Bothell campus, the Tacoma campus. We have over 100 people now that are working on 36 projects to try to figure out solutions to try to do more with these complicated mental health problems. We've gotten 36 teams started. This 88 number is a little out of date. It's over 100 now. And people are working on a whole bunch of really interesting things. You know, what to do about youth mental health, what to do about Alzheimer's disease, what to do about people who've had traumatic brain injuries, and so on. There's a big emphasis on how do we use technology to try to improve mental health. There's another big emphasis on what is it that we can do to keep our brains as healthy as possible. So there's this idea, you know, with our bodies, if you keep moving your bodies, if you keep exercising, and I saw you have some really wonderful facilities here in this building, it might last you a little bit longer. It might stay fit a little bit longer. What is the same thing like for the brain? What is it that we need to do with our brains to keep them healthy? And this is a whole, we have a whole group of researchers that are working on this. And so one of the things we're doing with this gift is we're thinking not so much about how does it break and when does it break. We're thinking about what about people whose brains don't break? What can we learn from them? So what about resilience? What about the opposite of when something breaks? And the same is true for example, post-traumatic stress disorder. So if you have a terrible trauma, actually I'm going to go to that in a minute, some of us really get damaged by that, and we develop something we call post-traumatic stress disorder, and we can't think about anything else. We have flashbacks. We really get stuck. But many of us don't. And we study the people who have the post-traumatic stress disorder. We're not so much studying the people who actually have had a terrible trauma and they don't develop that. What can we learn from them? So there's sort of a flip where we're now saying, what can I learn from people whose brains age well? What can I learn from people who have trauma and they don't develop PTSD? What can I learn from people who have an addiction problem and they can recover from it? Because so far the research has mostly just looked at what happens with people who have broken things. One of the cool strategies we're looking at is the ways to try to reduce the risk of Alzheimer's disease. We have a researcher, Jeff Iliff, who gave a wonderful TED Talk if you want to watch that. And what he's shown is that as you sleep, when you sleep, there is something around your brain called glymphatic fluid. And that glymphatic fluid actually removes sort of little waste products, little nasty proteins that you don't really want or need in your brain. And when you regulate that glymphatic flow, you can actually affect the risk of Alzheimer's disease. We're doing some really cool work In addiction treatment, we have a researcher who's up here at Harborview in our R&T building who's developing a vaccine for people who have been at risk for opioid addiction. You know, we have psychotherapies for people with addiction, we have drug therapies, but we're now actually doing research to say, can you give somebody a vaccine that either makes them not want to start to use that stuff in the first place, or not benefit from it when they are taking it? So, could I actually protect you from an addiction problem? So very, very new strategies. I'm going to skip these last couple here. A couple of other things that we're working on. We're increasingly recognizing that our brains and our immune system have a very, very close connection. So there's a whole concept of neuroinflammation, and as we understand that better, we might have new treatment strategies. We'll also come to understand that there's a very close connection between our brains and our gut. So we have something in ourselves called a microbiome. So that's the zillions of little creatures, little bacteria, other little creatures that live in us that we need, that actually keep us healthy. Most of that is in our gut, but depending on what's in your gut, that microbiome, it actually has a pretty powerful effect on how we feel, how we think. And we're now starting to say, could we use treatments that affect your gut microbiome to help people who are struggling with mental health and addiction problems? Some of these ideas, like much of what we do in science, sound a little nuts, but sometimes you have to try new ideas to sort of come up with something that really makes a big, big difference. So, I've talked at you for 45 minutes. I'm going to stop talking at you. I'd be happy to hear any questions you might have about any of the stuff that I've talked about. Thank you very much for your time.
If you have a question, hold up your hand and the mic runner will bring a mic over so you can be heard.
Okay, a few months ago,
Yes, I see
a few months ago, there was an article about a graduate from doctorate for clinical psychology, and it was taking 2 years before they can get certification.
Yes.
And that there was kind of a log jam there, and here we need those people online. What can be done about that?
Yeah, so I have a slide on this, but I didn't show it. It takes a long time to get a doctorate in psychology, 7 or 8 years. And then it may take you another year or two to get licensed, and you have to show somebody that you have 2,000 hours of supervised work experience. Those are all things that are pretty big barriers. So there are things we're trying to do, working with people in Olympia to see, can you streamline this? I think that is one answer. The other thing I feel like is, I don't think we should have to wait until we've had 7 years of training for somebody to have the basic skills to do what a psychologist does. We got a couple $1 million from the Balmer Group, which is another local philanthropist, to start a program where we're going to teach undergraduate students in psychology how to do evidence-based psychotherapy. So I feel like that stuff is not rocket science. You know, teaching somebody how to think a little differently, how to try things differently. There are some very simple techniques that we can teach people when they're in undergraduate school. That doesn't mean that they shouldn't go on to get a doctoral degree later, but I think we need to start much earlier than just waiting until we have a small number of people who've all become doctors. Okay. Yes.
I think you've given an absolutely excellent description of the situation in the world, or at least in the United States. I had a question, though, about some of the less serious problems that people have. I mean, if I hesitate to say anything about the population of a place like Horizon House, but I think most of the problems we have here are, quote, minor.
Yes.
That is, you live with them, you cope with them, and somehow you get by. And I wonder what your thoughts are about what can be done to make things better at a place like Horizon House with a large number of relatively effectively coping people, but where there are problems. Thanks.
Well, you gave me a great one. But I guess I have a couple of thoughts. One of them is, this is interesting, right? As I said in my very first slide, you know, you got a couple hundred people here who have had who come with a different computer, different hardware, different brain, who've had completely different life experiences, who have different ways of coping with things that are stressful, and now you all find yourselves together here, right? What is it that you can do with each other, for each other? I think a couple of things I would say. One of them is, you want those little problems not to become really big problems, right? So what is it that can be done, to try to prevent a person who is feeling like they're down a lot from getting really just profoundly depressed and never wanting to leave their apartment and never coming out? Sometimes, you have to just sort of, you don't feel like doing it, but you have to do it, and afterwards you think, oh, okay, that wasn't so bad. So when you see somebody who is really struggling, who's really withdrawing, what is it that we can do to kind of say, hey, come out, let's do something. Sometimes relatively simple things like that can be pretty helpful. But I don't know that I have the answer to what you said. I think you're all super smart people, and you've got some smart people here. Maybe this is something you all can put your heads together about. I don't know what you think about this, Jack.
You might mention Patrick Rowe.
Yeah, I have a colleague, professor in our department, Patrick Rowe. He's going to come and give you, I think, 2 talks, and he does work with older people who have depression and anxiety, and he works with that milder spectrum. So he sort of says, here's some techniques that can work for somebody who's not thinking of themselves as a person who's living with mental illness, but who's, who's struggling. And he will share with you some really neat little techniques that he's developed, and that we've tried in a whole bunch of different research studies to try to help people when they have that mild stuff. And I don't know what the dates is, but I think it's pretty soon.
21st of May and the 5th of April.
April 5, May 21st.
Wait a minute. April 21st and May 5th.
Okay, April 21st, May 5th. Patrick Rowe, really nice guy. I recommend you chat with him about that, because it's exactly what he does. He says, what do I do with people who are anxious, who are a little depressed? They're not full-on mentally ill, but what can they do so they maintain their functioning and they help other people? But I think there's a lot, actually, that you can do. Okay, other thoughts, questions?
Okay.
Yes.
I have a question about an immediate issue. We're going to get our ballots very soon for a special election that will provide something over $1 billion from property tax revenue in King County for 5 new crisis mental health crisis centers in different parts of the county. Would you comment on that and how that fits into the overall system?
Yeah, I'm going to be a little cautious because I'm a state employee and I'm not supposed to say anything about things that are on the ballot right now. So I'm just going to be a little bit cautious. So yes, so there will be a ballot where King County would like to take $1 billion of property tax money to build 5 centers throughout the county that would help you 24/7 if you're in a crisis. I think in principle, it's a really good thing. We have a tremendous amount of need for this kind of thing. I don't think it's the all-out solution for everything, because these things are built to take care of somebody for a 23, 24-hour period, and many of us will need help beyond that. So we need more than just crisis care, because otherwise we'll open a bunch of front doors and there's no back door, and it'll be really challenging. But I think in principle, yes, absolutely. There's plenty of people. You don't have to go very far to see that there are people who are struggling, that if we had a place where they can go and we could help them, it would be a good thing. But I don't want to comment on the very specifics of it, because like I said, it's active legislation, and that's something I should be kind of cautious about.
There was a picture.
Yeah.
I'm sorry, I'm next.
I just wanted to thank you very much. The presentation is very encouraging for those of us who have been toiling in the field for a long, long time. One of the things that concerns me is what is going to fund the treatment for the people who depend on third-party payments. We have struggled so long to get brain disease recognized as bona fide diseases worthy of payment, and the savings are so obvious for when that is done. Is there work being done to somehow deal with this issue, or to have an impact on those decisions that get made by the ones who tell us, no, you can't be treated, and no, we won't pay?
Yeah, so money drives a lot of what we do, and if there was more money, we wouldn't have such a lousy facility from 1871, right? We'd have something beautiful like we have for some other health problems, and the same is true for insurance payments. So if you don't pay well, if state Medicaid, pays very poorly for me or any one of my colleagues to see a patient who might be very sick and struggling and maybe has psychosis or has thoughts of suicide, and we could spend an hour with that patient and we might get paid very, very little, maybe $20, $30, $40, right? That's not enough money to make anybody who's trained as a doctor to say, I can really afford to do this. So absolutely, we need to work with our insurance companies, our payers, to say, if this is that important, let's pay it like we would pay the rest of healthcare. I think there are two good things. One of them is, we have now federal laws and we also have some state laws that have to do with something called mental health parity. So if your insurance company sells you care for your heart, for your lungs, for your cancer, they now also are required to sell you treatment for your mental health problems. Now that's a good start, but that's hard to implement. The second one is we have to convince people that the payment rates should be good enough. How do we do that? I think the best way to do that, frankly, is for people to say, many of us have our health insurance through our employer. So I'm a University of Washington employee, I have my health insurance through my employer. That employer contracts with an insurance company. And if I make enough noise and I say, the mental health services that you people provide me through my employer health insurance are lousy, I'm going to go to somewhere else, then there's a little competition. So I feel like I've seen that in the last couple of years. So Boeing, Amazon, some of the other big employers have all of a sudden started to say, we don't have better mental health benefits, we are not going to buy your health insurance plan. And I think that's basically ultimately what's going to drive up payment rates. Yeah?
There was a slide that was very striking in what was missing. It was a slide of maybe 15 people being trained for mental health practitioners or would-be. There were no, maybe one or two people of color, no black people. I think a lot of people in the audience reacted when they saw that slide. Do you perceive that to be a problem both within your immediate sphere of work and certainly for the state as a whole?
So you're speaking to the diversity of our workforce. So what you saw on this picture were actually, those are the researchers that are working on trying to find better treatments, and that's absolutely true. If you look at the workforce we have, at the university, it's not a very diverse workforce. And it's something that's been a huge priority for us over the last couple of years. So I will just share with you, this is news from this morning. So every year, we match a new cohort of psychiatry trainees in our program, for example. And this year, we just got our match results this morning, and we had a wonderful match. 25% of the people who matched into our program are people from backgrounds that are underrepresented in medicine. 75% are people who are people of color. And that's a huge effort that we're making right now to try to say, can we have a workforce that looks more like the patients we take care of? Because if everybody is a white person who comes from a very privileged background, it's going to be very challenging for us to really relate in a meaningful way to the people that we're actually taking care of. So we've made a huge effort in this area, and you were very astute in picking that up. But like I said, the thing that made me very happy this morning before I came here when we got our match results is to see that we were able to match. That's the future of us, to match a workforce that's a lot more diverse. So thanks for mentioning that. Yeah.
I'm very pleased to hear that. I have a question about peer counseling. I have a young person that I'm close with who's diagnosed 10 years ago maybe with schizoaffective disorder, who's now got that completely under control and has been doing peer counseling in a situation in Massachusetts after going through a long, very intensive training program. He's back home now, living here, and has done the training program here, which he finds much less good, much more superficial. But the question is, I didn't hear any mention of using peers in taking people who are scared into a situation where they can get professional help by being reassuring and the other kinds of things. I'd like to hear about that.
Yeah. So there is, I've had to go pretty fast over these slides, but actually. So this is a fairly new concept. So what about a person who's got their own lived experience with a serious mental health or addiction problem? In addiction, we actually have known this for a long time. Somebody who struggled with an addiction and recovered from it can be a fabulous, fabulous therapist, sometimes much more effective than somebody who's not got that experience. But this can also be true for any other kind of mental health problem. So there are some programs that train peers in doing what you just said. We have actually a really, really nice program right up the hill here at Harborview. If you're an inpatient with us at Harborview, you will get a team with a doctor, a nurse, a psychologist, a pharmacist, and a peer counselor. And what is the peer counselor? We call them peer navigators. The peer navigator is part of your treatment team, and their job is to help you not just while you're in the hospital, but to help you make a transition to when you're no longer in the hospital, because that can be a really, really hard transition for people. And we've gotten some state money to try to beef up the training for this group. I agree with you. There are other states, Georgia, Massachusetts, that have invested in these kinds of programs a little earlier than we have. But I think we're onto it. I think we are getting some support both from the county and the state to train peer counselors, and it'll be a very important part of what we can do to help people in the future. So thanks for mentioning that. Yes. Yeah. Both of you.
You mentioned the fact that you had a team which could be called 24 hours a day, but as I understand, it's only for the other doctors.
Yes.
So if a mental health person needs help with a patient, let's say with a crisis patient, and they would like additional information, they cannot call that group?
Yeah, right now it's right. Yeah, right now that consult program is for healthcare professionals. It's not for patients to call themselves. We have something else that I didn't show you a slide of, which is, and this is a federal thing, but we have it in our state too. There's a new number now for people to call called 988. So just like when you call the police, you call 911. If you pick up the phone and you go back to your apartment, you call 988, you'll get connected to somebody who will do crisis counseling with you. And this is a statewide thing. And the way we support it is when you pay your cell phone bill, there's a little tiny tax on it. For anybody who's got a cell phone bill that actually funds this 988 number. So that's a number that you can call, a patient can call, a loved one can call, and 24/7 you'll get connected to somebody who has skills and training in crisis counseling. The program we built is to support healthcare professionals, and we started that with doctors, but we actually this month are expanding it to any kind of healthcare professional who wants advice on how to help manage a patient.
Could you get back to that slide? I'd like to take down the number.
Of course. Here you go. There's actually 3 parts to this program. Again, I'm sorry I don't have so much time. There is you can call an adult psychiatrist. We have a child psychiatry version of this for anybody taking care of a child with mental health or addiction problem. That's run. It's called the PAL program. It's run by our colleagues who are working at Seattle Children's Hospital. Same thing, 24/7. You can call them. And we have a third program which is designed to help people who care for women during the perinatal period. So women who are either thinking about getting pregnant, who are pregnant, or who've recently delivered a child, because that's a very high risk and it's a very important period. And we have a group of psychiatrists who are very good at helping that population. And when you call this number and you're saying, I'm calling about a woman who is during the perinatal period, you'll get to talk to one of our 8 perinatal mental health psychiatrists. Okay, yes.
you foresee a need in the future for artificial intelligence as a psychiatric resource?
Hey, you're very up to date. Do I see a need for it? There's a need for it. How well will it work? I think we're all discovering. So what I would say is this. I am quite sure that 10 years from now, we're going to be using, artificial intelligence to augment what we're doing in our treatments. There will be computers that are smart enough to interact with us in ways that some therapists used to be able to interact with us. Maybe, I don't think it's going to be all a computer. I think it's going to be a human working with a computer, and a computer can practice some skill with you the same way that a human can do, for example, right? I think we'll have computers that are smart enough to listen to your voice and notice if something has changed. They might not know what's wrong, but they might say, when I listen to this person talk, there's something different, somebody should take a look at that. I think there's going to be computers that'll help doctors not make so many mistakes, because when we prescribe treatments, we could make a lot of mistakes. That's not that we're bad people, but when you're, some of you are taking a lot of medications, maybe 6, 8, 10 different types of medications, and actually the truth is nobody really knows what happens once you put the 5th drug into your system. How does that really interact? I think we'll have computers that are a little smarter, than some of us, and that doesn't mean that they replace us, but they can help us. They can say, hey, here's something you should take a look at. So do I think there is a role for artificial intelligence in augmenting what we're doing here? Absolutely. So we have, one of the things we built is a whole program on, it's called the Bright Center, on how could we use technologies like artificial intelligence to help us. We have a very complex electronic health record system now at the university, for example. We could have a computer mine that electronic health record and flag people who look to us like there might be something wrong with their brains. That's all stuff that could happen in the background where we don't need to rely on somebody coming in. So I'm not a guy who thinks this AI is going to replace us. I'm not a guy who thinks it's going to be the solution to everything. But yes, I do think that it's going to give us some tools that could help us do things that we've always tried to do much, much better. I think our computers are very good at some things, but they're not so good at other things, those computers up here. So I think there's a lot of potential for AI, yeah.
For those of you who may have to leave, please feel free to do so. I think Dr. Unutzer will stay and answer any further questions if you want to, come up and chat with him a little bit. Otherwise, thank you very much for being with us.